On the program this morning, we're trying to understand the connection between dyslipidemia and hypertension. You might be wondering why a high-sounding kind of disease, so to say. We'll be breaking all that down for you this morning, and it's all about our health. But I must tell you, this health talk we're about to really encounter this morning is powered by Novartis, which is a high-profile pharmaceutical company in Nigeria. They are interested in lowering the outcomes when you talk about diseases that relates to hypertension, and they want Nigerians to have the right information. That's why they are bringing this health talk to you this beautiful morning. So we say big ups to Novartis for making all of this possible as we embark on this special edition of Your Side Mirror. Now, Saturday was World Hypertension Day. That's every 17th of May. It's usually commemorated across the world, and it is time for we all to pay attention because this morning we want to shine a light on dyslipidemia, which is a silent contributor to high blood pressure and, of course, cardiovascular complications. We see that all the time when people go for diagnosis. You see people coming down with hypertension and all of that. So by understanding the connection between these two, we can take proactive measures, take proactive steps towards preventing and, of course, better manage our health. And to do justice to this conversation this morning, we have here in the studios with us Dr. Akinsanya Olusegun Joseph. He's a consultant cardiologist with Lagos University Teaching Hospital, LUTH, and he's right here with me. Dr. Olusegun Joseph, nice to have you in the building. Good morning.
Thank you very much. Good morning, everyone. Thanks for having me.
Great. All right, let's just kick it up right away. So we've been talking about dyslipidemia. Talk to me. What kind of a condition is that?
So dyslipidemia is a condition in which there is abnormality of lipids, of cholesterol in the blood. All right. Cholesterol has a profile. We have panels. All right. We have the total cholesterol. We have triglycerides. We have high density lipoprotein, which is the good cholesterol, and then low density lipoprotein, which is the bad cholesterol. We talk of dyslipidemia when, one, the total cholesterol is high. Two, if the total cholesterol is normal but the low density cholesterol, that's the bad cholesterol, is high. And then three, if the high density cholesterol, which is the good cholesterol, if it is low.
Right.
So usually a high low density cholesterol, low density lipoprotein rather, a low high density lipoprotein, which is the good cholesterol, plus or minus high total cholesterol, and then the triglycerides as well. If the triglycerides are high, we also say that this person has, cholesterol or fat abnormalities.
So let's break it down for the average person who might not really understand what a cholesterol is. Doctor, break it down for us. What is cholesterol?
Well, cholesterol is an accumulation of fats, really.
Good. So when we have too much fat in the blood, right?
Yeah, in the blood.
Okay. So how is dyslipidemia linked to hypertension?
Dyslipidemia is linked to hypertension in the sense that, number one, both of them cause what we call endothelial dysfunction. They affect the blood vessels. When there's dyslipidemia, there is dysfunction. There can be dysfunction of the blood vessel because of the endothelium that is, affected. What that does is to cause increased vasoconstriction. Vasoconstriction means that the blood vessel becomes tightened. All right, becomes tightened, and once that happens, the peripheral resistance, that's the factor that increases the force within, the pressure within increases, and then the blood pressure increases. So peripheral resistance increases as a result of narrowing of the blood vessels or constriction of the blood vessels, and dyslipidemia can cause that.
So that
will cause hypertension.
Right. So let's liken that to the pump system in our homes, the water pumps, the pump water system that we have in our homes. So if the pipes are blocked in one way,
clogged by debts, by a lot of things, that can, cause reduced flow to the tanks because of the blockage. Same thing happens. Yeah.
Right. And that's it. When you open the taps, you find out that the water that is coming out, the pressure is very, very low sometimes. It's as a result of those kind of blockage. Is that it?
That's it.
All right. So what are the major risk factors for dyslipidemia?
So the risk factors for lipidemia, one, it can be genetic. I mean, there are primary dyslipidemia, and then there are secondary lipid. So it can be genetic, it can be genetically transmitted. Two, the second risk factor, age. As one increases in age, with increased age, there is that tendency that dyslipidemia will occur. Three, obesity. All right, those who are on the big side and the fat side, they are more likely to come down with dyslipidemia. Those who smoke, so smoking is a major risk factor, all right, causes dyslipidemia. Increased salt intake. Those who take a lot of salt in their meals, there is a connection between salt intake and dyslipidemia that causes subclinical inflammation, and with that there is impact on the cholesterol in the body.
All right.
The race also, it's commoner in blacks than the whites.
You mean it?
Yes, it's commoner in blacks than whites, and then it's commoner in women when they attain menopause. All right, so menopausal and postmenopausal women tend to have more dyslipidemia than men. Before menopause is almost the same. And then the diets that people take. If you take more of saturated fats, the saturated fats that people consume, fast food and things like that, these are things that can cause increase them in cholesterol. Red meat, all right, red meat, cow, ram, goats, all right, skin, eyes and offals and all of that. Right. These are things that can increase the risk of dyslipidemia.
So how is it diagnosed?
Well, it's diagnosed by going for what we call lipid profile. Now, what some people do is they just go for total cholesterol. That is not enough. Like I said, the total cholesterol can be normal. If the total cholesterol is normal, you want to look at the other panels. The good cholesterol, which is high density lipoprotein, and then the bad cholesterol, which is low density lipoprotein. When someone decides to go for just the total cholesterol, it leaves it there. You are not aware of what the figure is for the low density cholesterol, low density lipoprotein, which is the bad cholesterol, and you are not also aware of what the high density lipoprotein is, which is the good cholesterol.
Okay.
Sometimes and then of course, when you do total cholesterol, triglycerides is also not done. So you're not aware of your triglyceride level. What we advocate is that one should go for a total lipid profile, in which in that profile there is total cholesterol, there is high density lipoprotein, which is the good cholesterol, there's low density lipoprotein, which is the bad cholesterol, there's triglyceride, and in most cases we even do very low density lipoprotein. All right, when the low density lipoprotein is high and the high density lipoprotein is low, all right, or when you do a ratio, there's a ratio we also check, but not to confuse people here.
Right.
Increased low density lipoprotein or reduced high density lipoprotein, that's dyslipidemia.
All right.
Okay. And then if the triglyceride is also high, it puts the person at risk of coming down with cardiovascular diseases as well.
Let's touch down on the symptoms now. So somebody who is coming down with very, very bad cholesterol, or perhaps very, very bad dyslipidemia, what symptoms or what signs will this show?
All right, fine. So this is where it gets a bit scary. Somebody can have very bad lipid profile, all right, and still have no symptoms.
You mean it?
Yes, it can be completely asymptomatic. In fact, there are no specific symptoms for dyslipidemia really, but there are a few things I'm going to point. That's why these things are called silent killers. So dyslipidemia, somebody may have it without having any symptoms.
Wow.
Right? However, there are few things that may just point to, okay, with this and this and that, let's do the cholesterol level as well. So one, if somebody has all the risk factors, you need to check for the cholesterol. So one, if somebody is obese, whether the person is symptomatic of anything or not, check the cholesterol. If someone has hypertension, check the cholesterol. Somebody is diabetic, as one ages, check, because this can happen. That's one. Two, those who complain of exertional chest pain. So you do some activity, and as you embark on those activities, maybe jogging, and then you have chest pain either in the middle or on the left side, that resolves, or you get relieved as you rest. That is called angina. Those who have dyslipidemia can have angina. All right. So that's one. Two, those who walk, people who have people can have exertional calf pain, exertional leg pain. You trek, and while trekking, just find out that you are having serious pain or maybe mild pain, and when you rest, everything resolves. That is likely to be, early symptoms of peripheral arterial disease.
Wow.
All right? And it's a major cause of, non-traumatic amputation worldwide. Okay. So if somebody begins to have such things, and it gets progressively worsened, then you know that you need to really, really find out whether this person has, dyslipidemia or not. Okay, and then for some other people, dyspnea on exertion, that's getting, having, being unable to breathe well when they exert themselves.
Right.
All right. Because dyslipidemia
they become short of breath.
Yes, dyslipidemia can be a risk factor for heart disease, for heart failure, and for heart attack. So some of these subtle symptoms, all right, we can point to this for us. All
right, and Lagos Traffic Radio 96.1 FM. We'll talk about how you can manage dyslipidemia and hypertension, and we're doing this courtesy of Novartis Pharmaceuticals. We're doing this because they want Nigerians to have the best of information as it relates to how we can manage hypertension. All right, let's get back to the traffic situation out there. Flash update coming in says, due to the closure of the access road at Adekunle Fajuyi and GRA via the railway, we now have more influx of vehicles connecting Ikeja underneath the bridge through the overpass bridge at Ikeja Long. As a result, a lane on the overpass is occupied by vehicles connecting Ikeja underneath the bridge by Awolowo Way, which is now affecting vehicular movement from National, with backlog stretching towards Airport bus stop. So take note of that. We can tell you that LASMA and of course other agencies there, they are collaborating with the Maryland Ikeja Axis traffic managers just to open more access routes to accommodate the influx. And that's the report coming in from the control room. All right, then. Another one says that the earlier reported incident on Acme Road has been evacuated off the road now, and normalcy has been restored. So take note of that. If you are navigating through that corridor, we did tell you that there was a truck that was loaded with iron plates that had its contents spilled on the road on Acme Road, in between Fumek and Acme Junction. But the good news, it has been taken off, so normalcy restored within that particular corridor. Very, very shortly, I'll allow you to also join the conversation so that you can benefit from what Novartis is bringing to your listening pleasure this wonderful morning. So, Saturday was World Hypertension Day. Dr. Olusegun Joseph Akinsanya. Let's just talk a bit on that so that people might understand what we are referring to. So, what is hypertension then?
Okay, fine. So, hypertension is elevated blood pressure.
I need you to speak closer to that microphone. Get closer to it.
Okay. Yes. Hypertension is elevated blood pressure.
Okay.
And we say that someone has hypertension if the blood pressure is 140/90 and above. All right, so 140/90 and above.
Right.
That's hypertension. However, in the US, the cutoff is 130/80 and above.
Right.
But WHO still retains the definition, the cutoff of 140/90 and above.
Will stand as somebody who's hypertensive, right?
Yeah.
What causes it?
Okay, there are so many risk factors. Shares risk factors with dyslipidemia, really. So, we have modifiable and non-modifiable risk factors. As one ages, the risk of coming down with hypertension is high. All right, so the risk factor, it increases with age. It's commoner in males than females until when the female attain menopause. So once, menopause and postmenopausal age is reached, the risk factor equalizes. Right. Now, it's commoner in black race as well.
So they look like Siamese twins.
Yeah, they look like Siamese twins. So blacks are much more at risk of coming down with hypertension than their white counterparts. All right, and it occurs even earlier in blacks. Okay. Those who take increased salt intake.
Right, that could also affect increased blood levels.
Salt intake can affect it. Increased body mass index, that's obesity.
Right.
Obesity is a risk factor. Smoking is a risk factor. Alcohol intake is a risk factor. Sedentary lifestyle is a risk factor
as well.
Yeah.
All right. How prevalent is hypertension? Let's. If we bring it home to Nigeria, if we're 10 men in this room, how many will come down with hypertension?
So for every 10 adults in Nigeria, about 3 to 4 will be hypertensive.
Wow.
So we have prevalence of between 34, it's reaching 34%. In some places up to 42% from place to place. Various studies have shown that it's on the increase.
Any age barriers?
No age barrier really nowadays. Before it used to be that the very young don't. They are almost immune, but now we know that. That has really changed.
You mean it?
Yeah.
So for somebody who's age 25 can be hypertensive?
Less than. We've seen people who are less than 20 who are hypertensive. Now hypertension can be primary or secondary. The primary is the one that I've described so far. Has no etiology, but there are risk factors. For the secondary, is linked to some diseases. For example, kidney diseases, thyroid disease, hyperthyroidism, hypothyroidism. Someone who is on some form of drugs like steroid to treat asthma. Once the ailment is treated, that person can be cured, so to speak. But for primary hypertension, which is the commoner one, accounts for 95% of hypertensive cases. It's not no known cause, okay, but there are risk factors.
Right.
These are the ones that cause more damage in our society, and in our climate is about 34%, and above.
All right. So I wanted you to talk on all that because there's a big link between dyslipidemia and hypertension. And thank you so much, Dr. Akinsanya, for breaking it down for us, especially on what hypertension is. So let's talk about the dietary changes and things that one should do, or perhaps the modifications that we should all apply in order for us to avoid hypertension. So what dietary changes can one use in helping to manage dyslipidemia and hypertension?
Okay, so there's what it's called DASH diet, there's what's called Mediterranean diet, but I'm going to just break it down, just talk about the components. Number one, cut down your salt level. Salt intake. Salt is a major driver in terms of hypertension.
But salt sweetens the food.
Yeah, it sweetens the food, but it also causes problem. It's just like sugar. Sugar makes things, the sweeter thing, the sweet things, unfortunately, are the things that cause problem. So lots of sugar, you get entertained, you get pleasure when you drink things that have lots of sugar. But we know that it can cause diabetes. All right. So what we're saying is that in moderation, cut down on this, and instead of going for everything salty, cut down on it. Very, very important.
Okay.
Cut down on fried things. All right. Very important. Cut down on red meats, like we said before. Cut down on fast food, things that are have a lot of preservatives, fast food and things like that. We need to cut down on them.
Right.
We need to take more of fruits and vegetables. All right, because we know that fruits have a lot of potassium, and potassium is a vasodilator that makes the vessels to open up so that blood flow can increase. So take fruits and vegetables, which will increase potassium. Take lots of nuts. Nuts are also very good. Groundnuts, walnuts, tiger nuts, cashew nuts.
Okay, all those nuts.
Yeah, the nuts are good, but preferably those that are not spiced. There are some of them that they coat with a lot of salt and things like that.
Oh,
they're already
okay.
spiced and things like that. The spice of stuff in it reduces, the benefits. So preferably unspiced ones, okay?
Right.
Then,
but there's some fruits that are
cereals
sweet.
are also very good.
There's some fruits that are sweet. Should one
fruits,
avoid them?
No. I mean, if you're not diabetic, you can take. Even for those who are diabetic, for now we don't say cut down on carbohydrate or cut down on fruits. We say take it in moderation, reduce the quantity,
right,
because they also need.
So like dates now.
Dates is fine. I mean,
it's
has
fine?
a lot of antioxidants in it. All right, but if you are diabetic, you need to to be very cautious with the amount you take.
All right, let's see if we can expand the discourse beyond the studios to also have the input of people out there. If you have any questions that relates to hypertension, and of course this one we just mentioned, dyslipidemia, feel free to connect with us on the program this morning. 09153877127. Okay, that's 09153877127. We have a consultant in the building. He's a consultant cardiologist, and you know what that means. He's a specialist in heart issues, and he's telling you this morning what dyslipidemia and hypertension can do to the heart as well. All right, 09153877127 and 08099120777. Doctor, how often should people get screened for dyslipidemia and hypertension?
At least once in a year. It's important that is done. I mean, it's very good for you to know the numbers that you have. So at least once in a year. For those who have dyslipidemia, you can, we advocate that you check it even more regularly. If you are placed on drugs, 3 to 4 months after, recheck and see whether you're doing well on the drugs that you have been placed on, whether it's helping to bring down the cholesterol or not, and then whether your lifestyle changes that you have embarked on,
right,
is working or not.
So for someone who goes to the lab to conduct a test, what kind of test will he request?
Lipid profile.
Lipid profile.
Yes.
All right. So now you know the test that you need is a lipid profile, but touch a bit.
And it's necessary that you tell them the full panel.
Okay.
Because some labs will just do the total cholesterol and leave out low density lipoprotein, high density lipoprotein, and the triglycerides. And that's not an incomplete result.
Right. I love the way you're using those terms. Panel. You're linking me up to solar energy and all of that. All right. So, but what are the complications that could arise from dyslipidemia and, of course, from hypertension? Okay.
So we call them cardiovascular diseases. All right, so one can have enlarged heart. From enlarged heart, there can be heart attack. All right, so heart attack, and it's increasing in our climb. So heart attack, heart failure. All right, arrhythmia. The heart can begin to beat in an irregular manner. There's also stroke. Someone can come down with stroke, kidney problems. Chronic kidney disease can progress to end-stage renal disease. One can come down with peripheral arterial disease, and that can also progress.
Wow!
And over time, it's the leading peripheral arterial disease is the leading cause of non-traumatic amputation.
Right.
So it's important that we get to know that. Sometimes it can also affect the eyes. All right, and cause reduced vision, and in some people they have bags of cholesterol around their eye, which is called xanthelasma.
So when you see all those bags on the eyes?
No, not just the bags, but
okay,
you will see, like a cheesy stuff around the lower eyelid.
Right.
All right, it's called xanthelasma.
All right, some messages are popping in here for you. This one says, "Good morning, Lagos Traffic Radio. Dr. Joseph, out of curiosity, how often do you encounter patients who are dealing with both dyslipidemia and hypertension?" Wally is sending this one in from Owode. Wally, thank you so much.
Oh, we see it every time, every week, or in short, almost every day. It's very, very common.
Right.
We run clinics 2-3 times in a week. We see lots of patients with hypertension and dyslipidemia. All
right, this one says, "Good morning, Victor. If someone has a family history but is currently healthy, what steps can they take to prevent both conditions?" This one's coming from Sharon. Sharon, thank you so much. So,
right.
If you feel you are healthy right now, but there's a history of that, what can one do?
First of all, please go for screening. Go check. Go for full screening, check your blood pressure, check your blood sugar, check your lipid profile, and do the things that will help you to at least know your numbers, know where you are. Then begin to adopt the lifestyle that will drive down these numbers. We've talked about them: exercise, reduce salt intake, reduce fried things, reduce intake of saturated and polysaturated fats, reduce intake of things that can impact on this, reduce or cut down completely on alcohol. Someone who smokes should cease from smoking, because these are things that can increase this. And for stress is also a major contributor to dyslipidemia and hypertension.
Right. Find
a way to unwind as much as possible. Go for break, go for vacation, take a break.
Okay.
All right. Yes.
I just want to say, when you say unwind, I mean, people want to unwind. They want to take alcohol. They want to enjoy.
No, not that kind of one.
All right. A question here says, amazing morning and happy new week. Concerning these conditions, are there any particular foods you always recommend or always warn against? Comrade what? Follow-on-show. Okay. Follow-on-show from Ikorodu. Thank you so much, Comrade Follow-on-show, for that. But I think the doctor just touched on that.
Yes.
Now, you're saying one should avoid fatty foods, right?
Yes. Fatty foods, salty meals, cut down your salt intake, cut down fried things, take more fruits and vegetables, take more nuts and cereals. Okay. You can also take green tea is very good. Dark chocolate, is very good. So cocoa drink you can.
But dark chocolate but it's also sweet now.
No, dark chocolate. I said dark chocolate.
Isn't
usually, dark chocolate, 100% chocolate is not sweet. If somebody gives it to you, you will think the person does not love you. I can tell you the truth.
Okay. All right,
and those dark chocolates have little or no saturated fats in them, little or in short, no sugar in them.
Wow. So that's the best one should take.
Yeah.
This was a please, sir, are there routine blood pressure checks? It says please, sir, are routine blood pressure checks enough, or should people also be checking their lipid profile regularly? Aduke, thank you so much. Checking blood profile, can that be a regular thing?
No, if you don't have dyslipidemia and you don't have any of the risk factors that we've talked about, once a year is okay. But if you do have, some of these risk factors, or you've checked your cholesterol before and they told you that it's high, you're on treatment for it, then you need to check it more than once a year. You need to be sure that the treatment you have, that you have been placed on is working.
Right.
So usually after 3-4 months, between 3 to 6 months, recheck it.
Okay.
And if it is normal, then you can get back to
your normal life.
Yeah.
All right.
Annual checks.
Right. Now you mentioned treatment right now. So what are the current treatment options, and who should a patient present to when you get to a hospital?
So if you have dyslipidemia, you can, or you want to find out whether you have or not, get to the hospital, visit, a doctor any of the doctors can help you to write it out. But if you have dyslipidemia specifically, one, you can see, a cardiologist, you can see an endocrinologist, you can see someone, metabolic, doctors and specialists who will help you to be able to, deal with this. And then depending on whether you have, complications or not. If there are renal complications, you may need to see a nephrologist. If there are cardiovascular, cardiac complications, which are the more frequent, you need to see a cardiologist. If there is diabetes alongside or obesity, you may need to see, an endocrinologist who will help you in the management of your blood sugar and the other things.
So the big question here, Dr. Akinsanya, can hypertension or dyslipidemia, can it be cured?
Well, it can. Dyslipidemia can be cured.
Okay.
Yeah, we have drugs for it. Can be cured, especially if you take the drugs, drive down the lipid, the lipid profile numbers,
right,
and then you stick to lifestyle that will encourage reduced cholesterol level.
All right.
I mean, the ones we have just talked about over and over, exercise and the rest.
Okay. All right.
Hypertension, on the other hand, can be controlled.
It cannot be cured.
It cannot be cured. I mean, primary hypertension. Secondary hypertension can be cured if you deal with the secondary cause. Like I said, I mean, somebody has a renal problem, you treat the renal problem, and then the person gets healed, the hypertension can go. But for primary hypertension, is only controlled, not cured. It's not like malaria.
And can you live till old age?
Oh yes, I have patients who are above 90.
Wow.
Yeah, 94.
And they've been suffering from that condition for how many years?
For more than 50 years.
Ooh, that's a big one.
Unfortunately, we have patients who are just diagnosed when they had a stroke.
Oh.
Or may get diagnosed when they have heart attack or have heart failure.
Right.
And then we also have patients who 1 year down the line of being diagnosed of hypertension, they have already had a stroke. Why? Because they are not adherent to their medication.
Quite unfortunate. Rather than Akpogbo and the flash update coming in there says this good movement from a co-bridge by NEPA inwards Akpogbo CMS bridge, and of course descending a co-bridge inwards Elegbata, all looking pretty good. Let's begin to round this off right now. So the message on this day, even as we talk about this dyslipidemia and hypertension, is what now, Dr. Akinsanya?
Yes, so the theme for this year is check your blood pressure accurately, control it, and live longer, because hypertension and hypertension related deaths still amounts for the highest cause of death globally.
Wow.
Yes, hypertension related deaths are still the highest cause of mortality globally, and that applies to Nigeria as well.
Right.
All right, so we need to check our blood pressure correctly. All right, control it if you are hypertensive. Take your drugs, please, and then the lifestyle modification, very, very important. And then that will impact on your quality of life and also impact on longevity.
We'll leave it at that one, right?
For cholesterol, please eat healthy, do things that will impact positively on your health and not negatively.
We'll leave it at that for now. We'll leave it at that for now. Dr. Akinsanya, nice having you in the building. Thank you so much for being here.
Thank you very much.
All right, he is a consultant cardiologist, and I'm talking about Dr. Olusegun Akinsanya Joseph. Of course,
Akinsanya
Olusegun Joseph, who is a consultant cardiologist with the Lagos University Teaching Hospital. And this morning, we'll be able to dwell on the connection between dyslipidemia and hypertension, and this is courtesy of Novartis Pharmaceuticals. I say a big shout out going out to Olorunfemi Omotosho, Dr. Olorunfemi Omotosho, and of course Dr. Angela Emechebe, both of them from Novartis, making this conversation possible this morning. We have to go. The program has been produced by Mike James, and I say a big thank you to our social media team, Okpayemi Shodunke, Remi Aluko, and of course Deborah Bolideku. Maximum shout out to you guys, and I also want to appreciate our executive producer Tayo Akonle. My name is Victor Oteri. I'm out. Stay very much within. We'll be back tomorrow for Your Side Mirror. Bye.
Nice. I take you on